As a continuation of the cardiovascular system and the diseases involved, we're going to today talk about the true heart attack causing ischemic heart disease. We'll again go over the mechanisms that cause the blood vessels to clog up and cause most heart attacks, and we'll talk about some of the other things that go along with it as well. First of all, we'll review the coronary circulation. The aorta comes off the top of the heart. It's taking fresh blood out of the left ventricle. Immediately as it departs the heart, you have two coronary arteries that branch off at right angles to that aorta. The left main coronary artery immediately then splits into the left circumflex and the left anterior descending coronary artery. It splits and continues as left anterior descending and also becomes the left interventricular coronary artery. So the left main does all of that left ventricle and the lateral part of the heart, the left side. The RCA, the right coronary artery, comes off the right. It goes down the right ventricle, down the back, and under the bottom. So it does most of the posterior, much of the inferior, and the right ventricle. The veins come back paralleling the arteries, but the veins are almost never a problem. It's the coronary arteries that block up. So here we have the right coronary artery. It's going down around back. It's going underneath. The left side catches the apex of the heart, but not most of the inferior surface. And here's the left main, which goes into the left circumflex, left descending, LAD, the left descending, anterior descending coronary artery, which continues this way, and the left interventricular comes this way and kind of goes down the septum. Blood flow through the heart is not continuous. When the heart beats, it squashes the blood vessels so firmly that they stop flowing pretty much. A few of the big surface ones continue, but a lot of the smaller stuff, especially on the endocardium on the inside, where it's pushing so hard against the blood that it flattens out those arteries, the blood stops. And then between beats, it has to flow extra fast. So especially the endocardium is susceptible to ischemia, because if there's even a slight blockage, you can't get enough blood between beats to nourish that muscle, especially during exercise. So the subendocardial pressure, we're going to see subendocardial ischemia, we're going to have subendocardial MIs, myocardial infarctions or heart attacks that will happen. It shows ischemia first. Coronary artery disease is abbreviated as CAD, and this is the blockage of coronary arteries so blood can't get to the heart muscle. The blood that's going through the ventricles to get pumped out doesn't do the heart any good. It's only that goes through these coronary arteries. And they are more susceptible than most of your other arteries in your body, because at night you sleep and everything can heal, but your heart never stops. Those blood vessels are getting smashed and smashed and smashed thousands of times a day throughout your whole life. They're more likely to develop some micro tears and damages, and if they get any sort of chemical or toxic inflammation, it makes it even worse and starts the process of developing coronary artery disease. The two ways that you can really block blood flow, and we kind of talked about these before, one is to have a coronary vasospasm, which is Prinzmetal's angina. Angina means chest pain, but Prinzmetal's is if you get all freaked out and suddenly your heart starts hurting, you have sympathetically stimulated the muscles around those coronary arteries, and they've squeezed shut, and part of your heart is not getting enough oxygen. The other way is to build up plaques and block it off. Here's Prinzmetal's again. the spasming of the muscle, and it can do damage to your heart. Most often it causes a transient chest pain that will then go away, and if you have it checked out later while it's not hurting, it doesn't seem to be anything wrong. The most common heart disease, coronary artery disease, is the building up of these atherosclerotic plaques. And these are the ones that are built up by that sequence of events, starting with inflammation, starting with an invasion of neutrophils and monocytes and stuff in the area that penetrate the endothelium, cause a certain amount of endothelial damage, carry cholesterol underneath the endothelium, and start this whole process of building the plaque. Your heart tries to combat this by building what's called collateral circulation. Anastomoses are blood vessels that will take blood from one place to another without exchange of oxygen or anything occurring. So if you don't get enough oxygen here, but there's a blood vessel here, and you have an anastomosis, it can open and deliver some extra blood into that area. One of the main benefits of regular exercise is the development of collateral circulation, more anastomoses. So people who exercise more, even if they have a heart attack, they're less likely to die from it because they open some collateral blood vessels and at least nourish part of that muscle to keep it from dying. Epidemiology, cardiovascular disease kills more people than anything else in Western societies. People usually don't starve to death here, and they're less likely to be blown to pieces by, outlaw groups or something than they are in some other places. But so what we are left to do is to die from by our own hand, by poor nutrition, poor exercise, and the like. Both men and women are more likely to die from heart disease than anything else. Men tend to die sooner because women are protected until menopause by estrogens. Postmenopausal women catch up, though. So by about age 70, they're about equal. And for years, they said men die of heart attacks and women don't, because women who were 80 who died of a heart attack, they would say it was natural causes. Where if a guy died at 60 of a heart attack, it was a heart attack. So, but in fact, it's a big deal for both groups. Change in diet, eating of more meats, more processed food, very fatty foods, fast foods that have been designed to make you, to sort of addict you to them, so that you eat more and more and more, supersizing your sandwich, supersizing your fries. And then sedentary behaviors, known as hypokinetic disease, meaning lack of physical activity, couch potatoism. People sit around, they sit at their computers. I do. I go home and I do my classwork on my computer. I'm not out running around and doing stuff like I did when I was growing up. Now, I not only rode my bike to school and back every day, it was probably somewhere between 3 and 5 miles. And, that was a certain amount of exercise, but I did it so I could get there early enough to play sports before school and stay after to play sports. And then I'd get home and I'd run around like an idiot with my friends until finally I had to go inside, eat dinner, and maybe do some homework. But kids don't do that anymore. On the weekend, they might go for a soccer match, but it's not the regular running around exercise every day. And this was actually pretty long ago that they did this study, and of the elementary school children that they checked, ages 5 to 10, 10% of them already had a cardiac risk factor, high blood pressure, high cholesterol, high glucose. And the obese children, a third of them had a risk factor, and at least one in each class already had two, putting them at an advanced risk for having heart disease by the time they're 5 to 10 years old. So these people now are now in their 20s and 30s and 40s. They're going to be moving into heart attack, age groups as you become medical professionals. You're going to have to deal with the fact that our country has become less active and heavier, and therefore more at risk for heart attacks. We're better at saving people's lives now when they have a heart attack, but convincing people to go back to the ways of more exercise and smarter diets is more difficult to do. Here we have the sequence again. I told you we'd see it again. Ischemic heart disease, it's kind of like a tumor. It's not a scab. It's a growing, vascularized lump underneath the endothelium of the cardiac blood vessels. Because of inflammation, that's what starts at first, whether it's physically damaged from being twisted and banged around or poisoned by toxins and cigarette smoke and the like, you have inflammation. The immune system responds. Neutrophils, monocytes, they adhere to the vessel walls. They penetrate the vessel walls, breaking open little spaces so they can go through, causing some vascular damage. They move across in there looking for bad guys to fight. There aren't any. They stay there until they die. Cells, they don't come back out. They stay in there and they arrive. They call them foam cells because they're full of cholesterol, which is a product that can be used normally to heal damaged cells, but because cell membranes have a lot of cholesterol in them. But instead they die and they leave this cholesterol behind, forming this fatty streak underneath the layer there. Smooth muscle cells kind of grow over the top of them and make a patch. Cells underneath are dying, pressure builds up, it blocks off blood flow to the area, capillaries get damaged, they rupture, and you start building up pressure in there until it pops and a blood clot comes out and kills you. Or if the blood clot doesn't kill you, at least the damage to the endothelium causes the whole process to start over again, and it happens over and over and over and over until finally it blocks it off. You have enough extra space in your blood vessels that most people don't even notice they have heart disease until they're about 50% blocked. Above that, you start noticing chest pain when you're doing exercise and stuff because you can't get the blood through the blood vessels when you need it. Penetration of the endothelium, delivery of the LDL cholesterol into that endothelium, which itself oxidizes and causes more oxidative stress. The smooth muscle cells migrate to create a patch on the top. The necrotic core is a dead center where things are being damaged and the cells are dying. It ruptures. And then to try to solidify all of this mess, you start sending actual bone cells, osteoblasts, in, and you calcify the area to make it hard enough so it won't rupture again. Once you start calcifying in it, you really can't make it go away. In the early stages, changes in diet, exercise, and lifestyle, you can actually reduce the size of the plaques somewhat when they're still soft and growing. But when they get hard, multiple ruptured, calcified, then they're there and you got what you got. What starts the damage in the first place that causes the inflammation? Well, like I said, it could be mechanical stress, just being twisted and bashed. Hypertension does it. High blood pressure in those blood vessels hurts the endothelium and causes it to start inflaming. Oxidative stress. Superoxide, reactive oxygen species. That's why eating antioxidants not only helps you prevent cancer, it helps prevent heart disease. It keeps the inflammatory response down. Oxidized cholesterol is an oxidative agent that causes some of this inflammation. Chemical stress, cigarette smoke, carbon monoxide, breathing of toxic fumes and whatnot, and some chemicals that are ingested can cause inflammatory distress. One of the reasons we're getting more cancers is because we have more exposure to more stuff. The air isn't as clean as it used to be. The water isn't as clean as it used to be. And we take in more things that have the potential to kind of change our DNA and make us either inflame or get cancer. Then the formation of the fatty streaks, the cholesterol below the endothelium. The endothelium is supposed to be attached to the smooth muscle. It's not supposed to be split off. So the separation of the endothelium from its substrate is bad for it too. That causes further inflammation. So again, the problems build on themselves. Here we have damaged endothelium. We have the cholesterol deposits, this fatty streak in here. We have the smooth muscle cells trying to grow over and form a patch over it. Normal, the fatty streak underneath, proliferating of smooth muscle cells to try to patch the damage under there. Stable plaque, it has this blob, but you've managed to grow new endothelium over the top of it so that at least momentarily it acts like a normal blood cell, a normal blood vessel. But a vulnerable plaque is one that ruptures and reforms and ruptures and reforms. Calcifications start forming in there, trying to add stability to the plaque. When I was in my PhD program, I started getting some chest pain. It was kind of regular, and it was right where my heart was, and I was pretty sure that I was having Prince metals. I was having some kind of problem with my heart. And so I went to the cardiologist, and he said that he suspected it was inflamed pleura, chest wall, but he sent me in for a CT scan of my heart because calcifications are essentially bone. They show up on an X-ray. They show up on a CT scan. And if you do a CT scan of the heart and you see a bunch of little white dots through the coronary blood vessels, you know that you have relatively advanced heart disease. Fortunately, I didn't have any of those dots, so he decided that I wasn't developing heart disease. I was just having kind of stress-related musculoskeletal issues. Calcifications, foam cells. Here's a tiny little fatty streak. You can't see it on this very well, but you can probably see it on your computer. A little light-colored streak underneath the lining of the blood vessel. And it tends to go all the way around. It may start in one place, but the whole endothelium will be kind of pulled loose, and this plaque will develop all the way around. And as it gets thicker and thicker and thicker, the lumen of the blood vessel gets smaller and smaller, till finally a small blood clot that might fit through there and not do any damage gets lodged, blocks it off the rest of the way, and you've had it. Here's a development of the plaque. It's about, looks like 80 to 90% occluded, and the rest of it gets blocked off by a blood clot. Normal size blood vessel, thin wall, large lumen, completely filled up with calcifications, smooth muscle cells, foam cells and the like, and finally a blood clot in the middle that blocks it off the rest of the way. If you see somebody's coronary blood vessel cut in half under a microscope, they didn't do very well. And unfortunately, the worst damage tends to be proximal, closer to the aorta, because that's where the pressures are highest and the stretching occurs the most. So these plaques tend to develop more thickly up close to the left main, and as you move farther and farther away and the pressures are less, you have a little less damage. So you have a bigger lumen and a smaller wall here. Well, that's not good, because if you're going to have a heart attack, you'd rather have one of those small vessels downstream get blocked, not one of the big ones up here, because then you are damaging a greater amount of your heart. There's our fatty streak. Keeps showing up. Here is a true atherosclerotic vessel. It's been sliced and laid out with the plaque all the way through it, incipient blood clots that are ready to break loose. Atherosclerosis, here it's getting noticeable, here it's pretty bad, and here it's real bad. Here's a heart that a major artery has been blocked off by a blood clot. This person obviously didn't survive. Another one, you can see as the blood vessel is opened, the plaque goes all the way around. If you closed it like this, it would be a circular plaque with its good old blood clot right in the middle. So how do you know somebody's having a heart attack? Well, electrocardiography is a good way to see it. ST segment depression means you're having ischemia, not enough oxygen to some part of your muscle. ST segment elevation means you're having an acute heart attack. You're having a heart attack right now. So that's one way. Chest pain. If somebody has the signs and symptoms of a heart attack, chest pain that radiates down the inside of their left arm and up into their jaw perhaps, a feeling of impending doom, sweating, diaphoresis, overly sweat, shortness of breath. So crushing feeling, some people says it feels like an elephant just stepped on their chest. Sometimes it doesn't hurt as much as it just feels like extreme pressure. ST segment elevation for an acute myocardial infarction. One problem is these typical symptoms are less likely to appear when a woman has a heart attack. And since all the tests were done on men in the early days, then when a woman has a heart attack, she's less likely to be properly diagnosed. And when she is, they said, well, she had atypical symptoms. Well, they're not typical for a guy, but they might be very typical for a woman. And if you're not sure, you do a blood test and you look for cardiac enzymes. Because heart muscle is different than skeletal muscle. It's different than smooth muscle. It has its own version of creatine kinase and its own version of cardiac troponin that if it's released into the bloodstream, you know it came from the heart. Dead and dying heart muscle gets leaky blood vessels, leaky cell membranes, and so stuff that's inside the cell leaks out, gets into the bloodstream, and you find the elevated cardiac substances in the bloodstream. If the heart attack's going to kill you, there's a couple of ways you can die right now. This cardiogenic shock. Remember, not enough blood pressure because of something your heart did, not because of sepsis or something else, but just your heart isn't beating well enough. You can have a very small area of your heart that is having its true heart attack, but the damage going on can stun the heart to the point where it stops beating, or it starts fibrillating instead of truly beating and not moving enough blood. So ventricular fibrillation, or, if your heart just stops beating, cardiac stunning, ventricular stunning, you wind up with cardiogenic circulatory shock and you die. Obviously, if your heart stops, you die within a few minutes. That's why CPR, though, can be so effective. It usually doesn't start your heart beating again, but it keeps your brain alive until somebody can come along and shock you back into a rhythm. And it could be that only a relatively small part of your heart is dead, and it can scar over and you can live. But if the whole heart stops beating because of the heart attack, you die before you get a chance to get better. So, cardiac shock, fibrillation, just a quivering of the ventricle that doesn't actually pump any blood. There's a phase for about a week after that where you're trying to take this dead piece of heart muscle and put fibrous scar tissue through it to make it strong again, where you're particularly vulnerable to having that ventricle bulge out and even rupture. You can have a ventricular aneurysm that stretches way out the side, so when you pump, the aneurysm goes like this. Instead of the blood going through the aorta, it just shoves, it's like puffing your cheek out. Or if it ruptures completely, then you're in real trouble too. So ventricular stretch, aneurysm, or rupture. And if you get your heart back to working the best that it can and it still isn't good enough, you get it started again, you save as much heart muscle as you can, but you lost too much, the heart muscle is so weak that you can't provide enough circulation, you die of heart failure. And we'll talk about heart failure in the next lecture. You can see kind of how that works as a short-term thing, or very commonly a long-term failure of the heart. Here's a heart that has had serious MI. Look how thin the ventricular wall is. There's almost no muscle left there. Here's a ventricular aneurysm. So the wall was thin so much, all there was that outer fibrous layer to keep the blood from just pushing out, but here's the puffing out of your cheek thing. Every time this pumped, blood's going that way instead of going through the aorta. This person obviously didn't do very well either. And here is a ventricular rupture. This is actually a little plastic arrow that somebody stuck through it so that they could take this picture. So this ventricle actually popped. if you're going to live and you're going to recover, here's how it happens. First of all, you don't let the person die until you can get them to a hospital, make sure their heart's still beating, do emergency bypass surgery to reperfuse as much of the cardiac muscle as you can. If they've had a heart attack, some part of their heart muscle died. But if you can keep that small, it'll scar over and the rest of it can possibly take over. What happens is, if you get, say, a dead spot the size of a nickel on your left ventricle, there's an area the size of a quarter around that that is stunned from ischemic damage and stuff. So it's not beating, but it's not dead. You can wake that up perhaps. It's called hibernating ventriculum. And there's an area around that that might be beating but barely, and one around that that's beating a little bit better. And if you can wake all of these areas up, you can restore a good part of the cardiac output. You can develop collateral circulation. If you already have some, it opens. If you survive and get to do cardiac rehab and exercise, you'll develop some collateral circulation. Of course, you do bypass surgery or angioplasty or whatever is going to be required to restore the blood flow the best you can. You form a scar over the part that's dead. You can't add new cardiac cells really in this case, but you can restore the ones that are alive. You can form a scar, and then you hypertrophy the ones that are left so that are a little bit bigger and stronger and can help make up the difference. Some of your treatments, well, if somebody's having a heart attack, you can inject epinephrine as a stimulant to restart the heart. They used to do that a lot before the advent of portable paddles and stuff, but they still try it if that's what they have. You can take nitrates, nitroglycerin tablets you put under the tongue, and they dilate all your blood vessels, and so this blood vessel that's not letting any blood get to part of your heart may dilate enough to let enough blood go through to keep some tissue alive. You can use TPA. Old school was streptokinase, but tissue plasminogen activator, TPA, is what we use these days mostly for clot busters to break the clot. So what you do is you put a catheter in through the femoral artery, and you push it up, you push it up, you push it up through the aortic arch and down into the heart. You feed it into the, or if you either put it into the heart or you turn it and feed it out into the coronary artery. And they're pretty good. I mean, they've got, controls so the thing can turn and go this way and turn and go that way. And you get this little wire, looks like a coat hanger, go down into that coronary artery that's blocked. And on the end of it, you have all kinds of stuff. It's a hollow tube, so you can blow streptokinase or TPA or something in there and try to break the clot. You can push a contrast medium through there so that you can take an X-ray of it and see where the blood is going and where it's not, so you can identify exactly where the clot is. And you can have a little balloon on the end of it that blows up and smashes everything out of the way. And that's angioplasty, and that opens it back up. You can insert a little nylon stent or a stainless steel stent or something in there to hold it open so it doesn't reocclude. So that's what we're doing here. We're going to try to keep the heart going. We're going to try to open it up. Aspirin or other anti-clotting agents. If you take aspirin at the very onset of a heart attack, it helps prevent additional clotting or platelet aggregation. This is what it really prevents. And then you can give various kinds of medicines to try to make it work a little better. You can give the person a beta blocker so that they their heart relaxes a little bit more and doesn't work beyond its ability to oxygenate itself. It blunts the exercise response so that if somebody, every time their heart rate goes up to 120, they get chest pain. If you can keep their heart rate below 120, then they can actually go out to their mailbox and get their mail and stuff without having chest pain. So beta blockers can help work for that. Coronary artery bypass graft, a bypass surgery called cabbage. And what they do is they take a big piece of your saphenous vein, usually. They can use the internal mammary artery sometimes if you only need one or maybe two rather short grafts. And they take this blood vessel, they snip it the right length, they cut a hole in the aorta and sew it in. They go past they bypass the blockage and sew it in distal to the blockage, and the blood flows again. Angioplasty is actually called percutaneous transluminal coronary angioplasty, PTCA. Most people just call it angioplasty. That's putting the balloon in there, spreading open the thing and sticking a stent in there to keep it open. That's done more and more, and this less and less. The old angioplasty is always closed up again, but they've gotten better at the process of putting the stents in and stuff. So now, a lot of times, this can be done. It's way less invasive than this, which cracks your chest from here to here and, is a pretty serious surgery. Diet and exercise. Don't let it happen again. Lose some weight. Stop smoking. Exercise. Diet. And people who've had heart attacks can run marathons sometimes afterward. We talked about circulatory shock. And again, in this case, you'd be having a cardiogenic shock. It's not caused by an infection. It's not caused by a car accident. It's caused because your heart isn't pumping enough blood. Here are your various non-cardiogenic shocks. There's another kind of shock that affects your heart's ability to pump, but it isn't the heart's fault necessarily. Obstructive shock. If you have effusion, or if you have cardiac tamponade that is filling the pericardial sac up with fluid and pushing so hard on the heart that it can't beat properly, or preventing the vena cava from dumping blood back into the heart properly, then you're going to have a lack of cardiac output even if the heart is otherwise healthy. A tension pneumothorax we'll see in the pulmonary section. That's a collapsed lung where every time you breathe, more air goes in the wrong space and it keeps shoving the lung over and over and applies pressure against the heart so that it can't beat properly. It can be lethal. And that's all plumbing problems. The other thing that can cause your heart to stop functioning properly are electrical problems. It's supposed to beat strongly, relax, beat, relax, beat, relax. You need the relaxation phase for blood to go in. You need the systolic contraction phase to push the blood out. It can't go too fast. It can't just quiver. It can't beat entirely at the wrong time, or you don't get as much blood movement as you're supposed to. So arrhythmias means there's something wrong with the rhythm, electrical problems. Now, we covered a little bit of EKG in A&P2, and if you take my EKG class, then you'll learn a lot more, or somebody else's EKG class. You'll learn a lot more about the specifics of these arrhythmias, but you should know generally what's going on here. Tachycardia means your heart's beating too fast. If it's just going up because you're exercising, that's fine. But if I'm sitting in the chair over there and my heart's 180, beats 180, there's no venous return from my exercise to supply that high heart rate, and your heart is beating without any decent amount of blood getting into it. You can lose your cardiac output because your heart's going too fast. Atrial flutter and fibrillation are even worse. That's super fast, like 300 beats a minute, or fibrillation is just quivering, and there's no contraction relaxation to let the blood in, let the blood out. Bradycardia, it's pumping way too slow. Premature ventricular contractions. Before the heart is supposed to beat, during the time it's supposed to be filling, something causes it to fire too soon and it beats. And you get a big, funny EKG tracing, and you don't get very much cardiac output because there wasn't time for the blood to fill before it suddenly beat. Premature atrial contractions means it beats too early, but at least the atria are the ones that beat early, so they are pushing blood into the ventricle, usually not considered as big a deal as PVCs. Everybody has some of these every day. If you have too many of them, it's a problem. If you have the normal number, you don't even notice them. A reminder of what a normal EKG looks like. P wave, atrial contraction. QRS, or the R wave more specifically, is ventricular contraction. The T wave is ventricular repolarization, so it can start over again. P, QRST, P, QRST, P, QRST. Here's your ST segment between the QRS and the T, ST. If the ST segment drops, you're having ischemia. If the ST segment moves way up here, you're having a heart attack. The very, very basics. A few different things that can go wrong and change the EKG. What if the atria contracts but the signal can't make it down and cause the ventricles to contract? Then you have an extra P wave. This is called an AV block. Atrioventricular block at the AV node. So the AV node beats, nothing happens. It beats again, nothing happens. It beats again, and finally a signal goes down and you have a regular beat. But it slows your heart rate way down, and it's not good. Every one of these P waves should generate a ventricular beat too. P, QRST, P, QRST. Not just every once in a while. Unusually rapid rhythms are tachycardias. You will hear supraventricular tachycardia, SVT, or paroxysmal supraventricular tachycardia is PSVT. That just means it comes and goes, comes and goes. And what's happening is the atria are going kind of crazy, or at least, some part of the upper heart is just forgotten about the SA node that's trying to control the heart rate. Instead, the atria are just going bang, 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 bang. And every time they bang, you don't have an AV block, the ventricles are beating, and you just wind up, the heart rate here is about 150, or even a little faster than 150, 160. And this wasn't a person who was exercising. Here's atrial fibrillation and atrial flutter. With flutter, you go flutter, 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 and every once in a while you get a beat. So the atria are but those beats are not making it downstream. It's just bam, 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 and then finally every once in a while you get a ventricular beat. Here the atria are just quivering. You don't actually see a P wave anywhere. at least not consistently, and the ventricles are just firing whenever they can. Irregular beat, atrial fib, the blood isn't moving out of the atria consistently, it's likely to clot. You need to take blood thinners of some kind to keep you from having a stroke. Ventricular tachycardia is lethal. Now, your atria aren't going fast and the ventricles firing whenever they get around to it. Instead, something has gone wrong with the electrical conduction in the ventricles themselves. VTach, ventricular tachycardia, the ventricles are just going jing, 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 jing. And it's so fast there's no time for the ventricles to fill with blood between beats. And this will become lethal if you don't resolve it pretty quickly. Ventricular fibrillation is the next worst thing. That's where they're not even going bang, 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 bang. Instead, they're just quivering. Often, you'll start out with a ventricular tachycardia, and because the heart is not pumping enough blood even to supply itself, it will beat worse and worse, and it will go into a ventricular fibrillation. And finally, asystole, your flat line. Basic heart attacks and arrhythmias.